Evening, everyone. Thank you for attending our event and webinar tonight. I have the pleasure of introducing our speaker this evening, Dr. Keshav Narain. He is a board-certified ophthalmologist with subspecialty training in vitreoretinal disease and surgery. His practice, South Bay Retina, is located in San Jose and focuses on a variety of conditions that affect the back of the eye and are ultimately related to systemic health. He utilizes advanced diagnostic tests to identify a range of biomarkers that identify both early stage ocular and systemic disease. His insights are gained through these tests, and they often lead to improvements in both ocular and systemic health. So without further ado, I'm going to let Dr. Narain take it from here.
Hi, thank you, Lauren, for that wonderful introduction, and it's a pleasure to be here speaking to all of you. I would like to just begin and slide advance, just hit the arrow. Yeah, I just need to. So I'm a vitreoretinal specialist, and I look at the back of the eye a lot, and I have no financial disclosures. But really, the message I want to get across here is that the eye is really a microcosm of the entire body. And so we have the ability to look at various different systems and get insight into other parts of the body through the eye. So not just looking at the eye for eye disease, but looking at the eye for general health. And, I sort of created this diagram that shows some of the areas that we're going to touch on. The neurologic system, the cardiovascular system. We won't have time to talk about the ocular surface, but I just want to touch on a few points and really how we can use the eye as a tool to improve our health. I'm not going to give you the standard lecture on cataracts and this is how many people get it with aging, because I think that is certainly important, but that's not the focus here. We will talk a little bit about cataracts, however, and glaucoma, but more in the context of how it fits in with overall health. So, the entire eye is affected by age, from the front to the back, ranging from things you probably are well aware of, cataracts, droopy eyelids, all the way back to changes in the nerve that are detectable on some of the more esoteric tests that we do. So really, I want to talk about circadian rhythm, and that's one of the first things we're going to talk about, and then a bit about myopic axial elongation, and I'll explain what that means, as well as presbyopia, which is needing glasses when you're older, for near and cataract, and really fit this into a framework of what are we really looking at when we do some of these tests? And some of these tests are very valuable markers for neurodegenerative disease, cardiovascular disease, and nutritional status as well. So beginning with the circadian rhythm, the circadian rhythm is incredibly important to our well-being. I think we all know that. We've all experienced jet lag, and we see how badly we feel when our circadian rhythm is not synchronized. And I want to talk a little bit about how that synchronization occurs and what is important in creating that synchronization. I'm not going to talk about melatonin supplements or anything like that. I'm talking about how do you stimulate that pathway in a more natural way. So many of you will, besides the cognitive effects of desynchronization of the circadian rhythm, sleep disturbance, irritability, you get GI and heart effects. People who don't sleep well or have a misaligned circadian rhythm will have greater body mass index, elevated triglycerides, cholesterol, etc. All this leads to aging. So this is well understood. So let's look a little bit at the pathway very quickly. This is your standard eyeball model with an inset showing the retina. And we all learned about the rods and the cones, and they exist here at this layer at the very back. However, in around 2006, another population of photoreceptors was discovered, and that's called the intrinsically photosensitive retinal ganglion cell. And this is a very interesting cell because there's not many of them, But those guys go directly from the eye to the midbrain. They go to the hypothalamic tract, pineal gland, and they regulate a whole host of other non-visual functions. And this is how your circadian rhythm gets set. So you can see how many connections. The one that we learn about in medical school is the suprachiasmatic nucleus, but there are certainly others as well. And I think the first thing I want to really emphasize is that it's a particular band of light that is important for circadian photoreception alignment or synchronization, and the terminology for that is entrainment. So to get entrainment, you need enough of the 460 nanometer, which is roughly this bluish color. And the other wavelengths that the other photoreceptors have are not as effective. And look what happens to the absorbance of these different wavelengths when you have certain blockers, blue blocking lenses, UV blocking, you don't cut it off, but with blue blockers, you cut it off. So we'll talk a little bit about that, but it's not just the wavelength of light, it is also the intensity. And one measurement of intensity is using lux. So 1 lux is defined as light candle at 1 meter away for an average human. And the amount of light that we get indoors is going to be well under 500 lux. In order to get the circadian synchronization, you need more on the order of 5,000, 10,000 and up. So if you look at this chart, you'll see on an overcast day, you still get 10,000 lux. So when you go outside, even on an overcast day, you are getting the right wavelength at the right intensity. So this is very important, not just for circadian rhythm, but also to prevent myopia, which you'll see is another function of this light that comes into the eyes. It says SAD, seasonal affective disorder. Treatment panels, they try to get 10,000 lux in those. And on a sunny day, it can be over 100,000 lux. But look what you have inside. Pretty low levels. Average nursing home, these are all well under 500, not enough to reset the. Yes, absolutely.
I have this app.
Yes, that's right.
It tells you, for example,
that's right.
Indoor is like 10 lux.
Yes, so indoor is very low.
Yes,
so this is important. And then the other factor, as we get older, as we age, with each decade of life, even before we get cataract, the opacity in the lens is enough that doesn't block vision, but it reduces the transmission of that blue light. So by the time a 95-year-old has 10% of the light absorbance in that wavelength as a 10-year-old. Now, at 45, you have about 50%. So it decreases as a function of changes in the lens, as well as changes in the pupils that occur as we age. This isn't even factoring in if you had a neurodegenerative disease and that accelerated the loss of the intrinsically photosensitive photoreceptors. Interesting experiment that was done. People get cataract surgeries when they get older, and now you have the option of a spectrum of different lenses that you can get. It's like sort of you can go shopping and you can get a multifocal, you can get a toric, and you can get a blue blocking lens was one of the options. So this is what happens with cataract surgery is when a 95-year-old gets cataract surgery, that will restore much of his ability, unless he gets the blue blocking lens. If he gets the blue blocking lens, he's going to have a hard time with entrainment. So this is a strong argument against the blue blocking lens in most cases. What is important, however, is that the blue light that you're exposed to at the beginning of the day. When you're exposed to it at the end of the day, you're going to activate your systems. You're programmed to wake up to that response. And what we can do, another option on your phone and most computers, is to put it in that twilight evening mode. That is very useful. I can't tell you how many patients I have that tell me they're not sleeping well at night, and I give them this trick, and they come back and they go, "I can sleep wait now." Yeah, because lots of people are looking at their phone. It's the last thing they look at before they go to bed. Oh, so-and-so sent me a message. Just make sure it, otherwise you are resetting to morning mode. So it's really important. So take home points, new classification of photoreceptors in the eye. 460 is sort of the sky blue. Circadian photoreception declines with age. Blue light exposure, the recommendation is 1 to 2 hours a day. If you can get that daylight exposure outdoor, even if it's cloudy, unless you have a seasonal affective disorder light available to you, you can probably substitute with that. And then look at carefully at what kinds of correction people select for you. Cataract surgery comes with lots of options these days. And there's even a fair number of people getting cataract surgery in lieu of refractive surgery, because that way they just have one procedure and they're done. So this is something to consider. So the answer to blue blocking lenses is in most cases no. It does make sense to use sort of these apps that will reduce your blue light exposure towards the evening. Sorry, question.
Oh, yes. Thank you. This is very interesting. So I am following this Stanford neuroscientist called his name is Andrew Huberman.
Oh yeah, he's the top podcaster now. Yeah, I know Dr. Huberman. Yes.
He recommends like at least 15 to 20 minutes sunlight intake early in the morning.
That's right. That's right.
Within minutes after you get up.
Yes.
It will adjust like your circadian rhythm. In the meantime, maybe get another 15 minutes sunlight.
Take a walk at lunchtime.
Exactly.
Yeah, go outside because we're all indoors. So very important, and not just for circadian rhythm, but now I'm going to show you how many of you have kids or are planning on having kids? Yeah. So there is an epidemic in myopia. Lots of kids are getting very nearsighted. Myopia is when you can see it near, but you can't see it far, and the image is focused too close. And why does that happen? First, let me talk about why you don't want it. Why it's not just a matter of not wanting to wear glasses. When you are myopic, you are at more risk for retinal detachment, macular hole, premature floaters, premature cataract, all kinds of things. Glaucoma, very common. Many changes occur in that eyeball. That eyeball is longer than a normal eyeball. It is physiologically different. So lots of reasons to avoid myopia. So these are typical myopic retina images, and they're showing the incredible amount of distortion that you see in the back. So in the back, these areas are kind of hollowed out and pushed out. And this is a very elongated eye. The normal length is 24 millimeters. This is a 30 millimeter eye, so significantly elongated. Somebody was doing, people have tried to stop this, but they weren't using the right technique. They tried to put a strap behind the eye. Well, that's not the answer. And I will show you what the answer is light, as you may have guessed. But just a little bit of epidemiology. Right now, this is what we mean by epidemic. There are certain cities where it is so high, the amount of myopia, it's really high. And that's because in a lot of the Asian countries, it's hot outside. So you go indoors, you don't go outside and play. And places like Singapore, places like South Korea, you go to school. And then when you finish school, you go to another school. And that's where, it's very common to go to school again. They're very active, great students, but they're not getting enough light and myopia nuts. So these are the factors that are important for myopia. How did we find this out? So they did a huge number of studies that looked at what are the factors involved in myopic progression. Those studies did not come from the US. They came from places like Taiwan. Singapore has an excellent study. Sydney has an excellent study. All of them came to the same conclusion, that it is the outdoor activity. Again, getting back to that 1 hour a day. And you can see down in that corner, it says keep myopia at bay, go outdoors and play. That's in every classroom in Singapore. So these guys are really on it now. They're very proactive. And so what they found is that kids that went out for that much time had a statistically significant decrease in progression of myopia. So really, really important to get the kids outside. If they're doing homework, maybe do it outside, playtime, etc. What actually happens in myopic elongation? Well, they created a model in chickens. They made a chicken very myopic. They induced myopic elongation, and they found that it's a bunch of growth factors that facilitate this change, remodeling. So the whole eyeball is really affected. And this is the slide that impressed me the most, is there is significant thinning of the choroid. So what that means is there's thinning of the layer that is most important for blood flow to the eye. This may explain why high myopes have so many problems. So if we can reduce that, now most of this pathway is largely sensitive to violet light. So before we're talking about blue, of course, if you go outside, you get everything, right? But if you were to just look at which wavelength is the best, turns out violet light is the best for reducing myopic progression. Pay attention to that second image of the eye, and you see the choroidal thinning. You can see like lots of changes that occur in the structure of the eye, which are not good changes. So violet light. So this was a cover of Nature a few years ago, and just showing you like everybody's wearing glasses. Yeah. And so it's quite interesting. In this country, we haven't really taken that point to the classroom like they have in a lot of the Asian countries. I think the refractive surgeons would not be happy if that happened. I don't do refractive surgery. Instead, I take care of people who have complications related to high myopia. But there's a second point that I wanted to make here. So make sure the kids get outside. A lot of adults, I was just talking to a colleague who's a retina specialist in San Diego, and he said he didn't become myopic till he went to medical school. So maybe he wasn't going outside as much, and so it is something that can happen in adults as well, but start early. Presbyopia, that's the other opia. So presbyopia is something that occurs when we get older as a consequence of our lens becoming less flexible. And we really didn't need to worry about near vision that much until when were glasses first seen on the historical record? This is one of the earliest, 1352. What was invented in shortly after that time? The printing press. So now we have books. Now all of a sudden it's really important to look near. So now people recognize, oh, you need glasses for that. So started making glasses in Venice, Murano glass. That was one of its original goals. And then Benjamin Franklin did, amazing guy, also created the bifocal. So you could see both near and far with one pair of glasses. So why do people get myopia again? It's because our lens cannot change shape. So up here is the top, on the top is the lens in non-accommodated form. So that means looking at distance. But when we want to look near, we want to be like a multifocal lens. Just like if you take a cell phone, you try to take a picture of your, something really close to you, it's going to be out of focus unless you change that macro mode, right? So your eye doesn't have multiple lenses to choose from. It has one lens. So the shape of that has to change. The ability to change shape decreases as we get older. And it's very linear with age. You can see here's the graph. And it also corresponds to the loss of what's called accommodative amplitude or multifocal. Yeah. So the good thing is there is treatment for it. You can certainly get presbyopia earlier. And there are a variety of ways. Here's some papers. One is dry eye. This researcher felt that dry eye, which is short tear breakup time, is one way to measure dry eye, is something that can accelerate the development of myopia. Certain medications, latanoprost is what we use, is one of the glaucoma drops. And then the other thing was, it was noted that presbyopia developed earlier during COVID-19. So lots of things, maybe indoor work. And then I want to briefly mention something that we all are probably familiar with. We probably all have a relative who's had cataract surgery. And I tell patients that if you live long enough, you will get a cataract. Now, that said, I have a couple of 90-plus-year-olds who have not had cataract surgery. And those are the super agers that you want to study everything that they do. Is it just genetics, or what are you doing in your life? But the vast majority of people will have cataracts earlier than that. And why does that happen? The cataract, the lens is a living thing. So there's living tissues on front. All of this slows down. But really what's happening inside with the lens proteins is they become misfolded. And that misfolding is independent of light. So we all know that UV might be a factor, that if you're a welder and you don't wear your glasses, you're going to get a cataract really early. However, the misfolded proteins occur at a very early stage, and it's very linearly related to age. In fact, you can tell how old a mammal is. For instance, the whales that were caught in the North Pole, and I'll talk about those, the bowhead whales that live over 200 years old, they measured one of the ways they verified the age was by looking at their lens proteins. So it's a very linear change. So here's some examples of cataracts. We are very specific about how we classify them because where the opacity is determines what type of effect. And some have very little effect, even though there's lots of opacity, because it's in a layer of the lens that is not that high impact on the vision. There are, besides age, the second most common cause of cataracts is medication in my practice, because we have patients who are on steroids. So steroids and a handful of other medications are well known to increase the likelihood of cataracts. Kids who are on steroids for juvenile rheumatoid arthritis get cataracts. Nutritional deficiencies, which we hardly ever see in the US. Diabetes, metabolic disease, genetic predisposition. Trauma will certainly give you a cataract. And then excessive UV, when the ozone layer was thinning out and everyone was getting too much UV, that was one of the concerns, that we'd have a surge. If you go to places in South America, which are at high altitude, those populations get cataracts much sooner. And that is likely because they're getting more UV. But if you look at our eyes, and I also get this question from patients who come in and they go, they feel very guilty that they haven't been wearing sunglasses. And I always have to reassure them that it's not that important, because your cornea shields most. Sunglass manufacturers will hate me for saying that, but and most ophthalmologists will tell you otherwise. But if you look at the actual numbers, I mean, we've been programmed to kind of think that we need to wear sunglasses outside. Well, you're blocking your circadian function. You're probably, if you're a kid and you're wearing sunglasses, you're not getting enough violet light. And turns out that you do a pretty good job of blocking much of the UV. Just your cornea alone takes out a lot of it. Your lens takes the other portion of it, and that does increase the production of cataract. Recently, there was a release of a medication that was supposed to help you read, a drop that you can use. And what that drop is, it's a clever rebranding of an old drop that we used to use to constrict the pupils called pilocarpine. And when you use a low concentration of pilocarpine, your pupils constrict. And if any of you do photography, you know what happens when you have a pinhole. You have a very long range of focus from near to far. When you have a wide open aperture, then you have to be very careful about what you're focused on. So if you make everyone sort of pinhole vision, which is what that drop does, you can kind of get over it, but it's a temporary fix. So presbyopia and cataract. So this is the fun slide, and this is a bowhead whale. And I had mentioned a little bit earlier that the bowhead whale can live as long as, they think, over 200 years, which is pretty remarkable for mammals. And one theory about aging and cancer was that the more cells there are, the more substrate there is for mutation, and the more rapidly we should age. But the sort of bowhead whale defies that. The other interesting thing about the bowhead whale is it doesn't get cataracts. So the story with how they found out these whales were this old was that Inuits, every year they're allocated a certain amount of whales that they can hunt. And they caught a whale, harpooned a whale, that already had harpoons in it. When they were shaving off the blubber, it had harpoons. And those were harpoons that were made like in the late, like 1800s. like 1899 or 1875. And it was like, how did this happen? This whale couldn't be that old, could it? And then they sent the eyes to a lab where they're doing the crystalline aging, and lo and behold, it turns out they have a whole bunch of things going on that facilitate this longevity. No cataracts. It's remarkable. And we can theorize as to why that is, but we also they did do deep sequencing of the bowhead whale, and they found a handful of enzymes that were like very different than most other whales. So yeah, so the answer may lie there. This picture of the Inuit gentleman, he's wearing Inuit sunglasses, and they're made out of walrus, and they were first made long before the glasses were made in Venice. They were date back to, they say over 2,000 years ago, they were using these. So they were limiting their UV exposure. I don't think you can get those at lens crafters. Interesting. Yeah, it would. Very nice. Any questions so far? So that was about light and its effects on the eye and our lens, circadian rhythm, myopia, presbyopia.
So you mentioned the drops that temporarily resolve some things. So is there any things that average out of the effect, so to speak?
So there was a drop that was in phase 2 and it failed. Novartis. Yeah. So far we haven't. Yeah, we haven't been able to slow that pathway down or even turn it backwards.
Oh,
yeah. Yeah. So
yeah.
sorry.
And Dr. Narain, we actually have one question.
Yes.
Even virtually. So the question is, I'm curious if the benefits of natural light exposure outdoors is inhibited or blocked by wearing contact lenses for those of us with myopia who are daily contact lens wearers.
Yeah, so unless it's a specifically labeled as a blue blocking lens, it would not. Most of them, just because the material that they're made of will block the UV light, which is good. But it will not block that blue spectrum, which we need, that blue and violet spectrum. Recently, they came out with a intraocular lens, which was blue blocking. And that was supposedly because there was one line of reasoning that blue light was more damaging to the macula. That hasn't turned out to be that true. We have pretty good mechanisms to maintain. So contact lenses are fine. Yes.
And we actually have a follow-up question. Someone asked, are you saying wearing sunglasses is not good for eyes in general?
Wearing sunglasses to the extent that you are inhibiting your circadian entrainment is not good. So you don't want to wear them all the time, certainly when it's very bright. But I have patients who feel like they need to wear them the minute they leave the house. And you are shortchanging yourself of that full spectrum of light for a sufficient amount of time if you do that. So my advice to patients is, you know what, wear a hat. Then you won't get the, that direct sun, but you get the benefits of full spectrum. And sometimes, yeah, you're out on the water and you need sunglasses. I have sunglasses. I wear them sometimes, but I don't wear them all the time. And there was a time in my life when I thought that was better to do. Yeah, just, is that?
Great, thanks so much.
Okay, so I'm going to dive into neurologic disease, the brain and the eye. And in med school, we learn about these really bad things that can happen that are manifest in the eye, like a pupil involving third nerve palsy, and that represents an intracranial aneurysm. I'm not going to talk much about that. That certainly is one of the manifestations, but I want to talk about some of the other things. Well, dry eyes are common. Corneal nerves become less sensitive with certain conditions, so that facilitates dry eye. But glaucoma is a big one. And I'm going to talk a little bit more about that. And so this is an animated slide. So this is saying that a borderline nerve, so your optometrist or ophthalmologist may have looked at your nerve and said, you have a large cup to disc ratio, and that's borderline. We're going to follow up on that. So a borderline nerve can be much more than that, much more than just glaucoma. There's a variety of other things that can cause the nerve to look like that. And here's a little short laundry list. And what I really want to emphasize is that This all relates back to the body. So there's both local and systemic factors. So our optic nerve, which is sort of a representative of it has been now recognized as a representation of the entire central nervous system, in the sense that neurodegenerative diseases like Alzheimer's, Parkinson's, ALS, they have measurable impacts in the eye, and we think in the nerve as well. In fact, that's been documented. So what else affects the nerve? Blood flow, microvascular changes. We know vitamin B12 is the critical one. All of us vegans take vitamin B12 supplements because that's something we may not necessarily get in plants unless you eat water lentils. And then neurodegenerative disease. So it is very common to see what looks like glaucoma, but is really part of an overall neurodegenerative deterioration. Local factors have been overly emphasized to us in med school because that's where we first learned about glaucoma, was high eye pressures. Intracranial pressure, brain tumors, et cetera, will also affect the nerve, and blood flow to the nerve or ocular perfusion pressure. I want to talk a bit about glaucoma because almost everybody is at risk for it. Most frequently seen in people who are over age 55. The risk factors, notice I say risk factor, not definition, is a high intraocular pressure. So my next slide, you'll see, is basically, that was the blood flow slide. The other risk factors, myopia, as we discussed, diabetes, which affects blood flow, high blood pressure, constriction to blood flow, anemias, anything where you go compromising some of the oxygen and nutrient delivery to the nerve. And there is also an age-related decline in nerve, but it's slow. It's like 1% a year. So we don't have to panic about that. People with neurodegenerative diseases typically have this happening more rapidly. And I'm going to skip this slide because it's just anatomy. And basically, these are the three elements we talked about. Artery pressure, pressure of blood going in, the eye pressure, which is just one of the factors, and brain pressure. Normal tension glaucoma means your eye pressure is normal, but you have glaucoma. Turns out this is very common. We were looking for glaucoma in people with high eye pressures and missing more than half of it. 30% in the US, up to 90% in Japan. So most of the glaucoma that they see in some countries is normal eye pressure. That eye pressure test, remember the eye pressure is like blood pressure. It varies according to time of day. There's a lot of different fluctuations that occur there. So normal tension glaucoma is a real thing. It does increase with age. There are some genetic predispositions. People who are myopic, again, are more at risk. And the problem is when you're myopic, your nerves look different. So we can't use the traditional, the cup to disc ratio, or the nerve looks like glaucoma. We have to test it. And other thing I want to mention that is a newly discovered risk factor for glaucoma is sleep apnea. Probably a risk factor for everything, right? Cardiac disease, so many things. Hypertension we mentioned. So how do we measure the nerve function? And traditionally it's been the eye, just the visual field. Now I'm showing you a picture of a visual field up here under the function. Here we go. Yeah. That's the type of visual field testing we do in my office. It's called a microperimeter, but I use a visual evoked potential in addition to an electroretinogram. And the difference with the visual field and the VEP and the electrophysiology is subjective versus objective. And anyone who's done a visual field will know what I mean, because it's really easy to make a lot of mistakes. And if someone reads that, oh, you got glaucoma. Well, the reality is probably the first time you're doing the test. And so, and a lot of patients, elderly patients, patients with arthritis, they can't hit that little button enough. And so you can't use this metric to make such an important diagnosis. Again, ours is one of the few practices that uses an objective metric, which is the electrophysiology. And this is like in cardiology, you use it all the time. You do an EKG. Well, imagine if we tried to diagnose your disease just by checking your pulse and listening to your heart rate. That wouldn't be enough. we get much better information if we use multiple modalities. Structure, it's great to look at structure. We have some really nice devices that will give you the microstructure of the nerve. The problem is, by the time you see change in the structure, the damage is done. You lost a quarter of your vision. I guess you have glaucoma. We have to treat you now. That's kind of a backwards way of treating it. That's not ideal. We really want to know beforehand, oh, your nerve is starting to have dysfunction. And I put an image of, this is the structural test. This is a patient of mine who I saw recently who has some pretty severe glaucoma in his left eye, and you can see the machine will highlight all these. The damage is done in this gentleman. So he already has a field defect. There's his field right there. And he already has that damage, but really we want to focus on the right eye. He came to me for that defect, but I focus on the right eye, and that's this column here. OD is right in ophthalmology talk. And so really the key here is to find the disease early before the damage is done. And so use more than one metric. This is the classic visual field that most ophthalmologists in the country are using. It's a $10,000 machine versus this machine, which is a $50,000 machine. They pay the same. So guess which one most people are going to get? They're going to get this one. And you can see how only the best test takers. So I have a lot of engineers and techies who are really good test takers. Most of the time, that's not the case. You know, your 78-year-old diabetic female is not going to be a great test taker, you know, and the instructions, you know, in different language. So in other words, this is not a great test, even though this is the current standard for glaucoma diagnosis. I am challenging that here today. You heard it. I use microperimetry. Again, it is subjective, but we're projecting the light into the eye rather than having people search for it outside. And that way we know, and that way we can tell you where in the eye that light point went. So we can see exactly, oh, you missed that one. Okay, clearly that part of the retina or that field, that area of the nerve is affected. Again, this is the paper that kind of underlies the fact that in their study, 52 of the 50, they were very positive. They said 52% of patients performed reliably. That means like a whole lot didn't. So why are you using that metric? It is expensive to do electrophysiology. Most insurances do, however, cover it. So that's the good thing, is that most, I will say there's one, should I mention names? That doesn't, and they probably don't cover anything. But really, by not covering it, you're missing the boat on early detection. And it's a really easy thing to analyze compared to reading an EKG. We learned in med school to read EKGs. This one, you're only looking at two factors. You're looking at amplitude, that peak latency, that P100, 100 milliseconds. That's the time that it should take for the light to get from your eye to your brain. If it's more than 117 milliseconds, guess what? That's disease. And we see that before there's damage to the visual field. So this is revolutionary. Why isn't everybody using it? I don't know. It's available. And the other thing that we find with VEP is that there is a predictable change in age. So people are measured against their own age cohort. So you see there's changes in, these are different types of VEP, multifocal, etc. So we're looking at that first 100 milliseconds, 120. And what's even more interesting, and is probably a big area of future research, will be looking at what happens at 300 milliseconds, because now you have that image in the brain, and that's where you pick up markers for Alzheimer's, ALS, and my hypothesis is that you find specific signatures if you look hard enough, with enough data. This is the validation for electrophysiology. So the science is there, it backs it up. It's not like it's a new thing. I don't know why, and thinks it's experimental when it was actually created in the 50s initially. It was very hard to do in the clinic, so you'd have to send someone to a lab to do it. Now the equipment is such that because of Moore's law, we have it in our clinic, and it's available. This is what VEPs look like in different diseases. So again, getting into different diseases that affect the eye, as well as neurodegenerative conditions. The other thing that is new is blood flow. We can look at your eye now with instruments in our clinic and look at your retinal vascular perfusion without giving you any dye or injection. We have a machine called an OCT angiography machine, optical coherence tomography angiography, and it uses this system to basically show you where blood flow is. And if you look at blood flow around the nerve, you can see in people with glaucoma, they have compromised blood flow around the nerve. So it really kind of ties together with that idea that we should not be focused on that pressure factor. We need to look at the big picture. So in my clinic, we use something called SLT. It has an 80% success rate in the largest trial. It is now recommended as first-line treatment for glaucoma in most parts of the world. In the US, there's still a lot of prescribers who will start patients off with drops, either because they don't have the equipment or that's what they're comfortable with. Drops in the largest study were 50% effective. And that is for people who completed the study, used the drops, and actually had a reduction of eye pressure. So all of those factors were favorable. Only 50% had reduced progression. That's not great. So our drops are really not the answer. And I know pharma companies will hate me for saying that, but that said, we still use drops, but that's not the answer for most glaucoma. Systemic risk factors we talked about, exercise, nutrition. So exercise is known to be neuroprotective, and that includes the optic nerve. Nutrition, of course, sleep without apnea, correct your blood pressure, correct your blood sugar. SLT, what is it? It's a short pulse of laser. It is a regenerative treatment in my mind, and others. What it does is it's not really lowering eye pressure that much. It lowers the eye pressure minimally, but it results in a cytokine cascade. So you're actually not burning with the SLT. You're warming up, you're changing gene transcription. You may have heard of something called a heat shock protein. So heat shock proteins come out when you hit the trabecular meshwork with this laser, and that impact is far more beneficial than the drop. That's why you get an 80% reduction in progression rather than a 50%. And what are those cytokines? So they actually characterize them. This was done by one of the most brilliant glaucoma researchers who unfortunately has passed away, Jorge Alvarado, who was at UCSF. But he showed upregulation of certain factors, downregulation of other factors. He did one of the microarray studies and really delineated it well. And I think it's underappreciated what he did. We look back at our data, and this was a few years ago. Now we have a lot more people who have had the SLT, but we found that a good number of them normalized their latencies after. Now, when I was in med school, we were taught that once you got glaucoma, that damage is done. We have shown, and others have shown now, that if you catch it early, if you catch it earlier, it's reversible to an extent that you can normalize your visual evoked potential. You can normalize. I've even seen improvements in the field, which I still is pretty mind-boggling, because again, we were taught, once you have that damage, it's done. So it's worth trying. Does it happen all the time? No, obviously not. There's other factors involved. So this was a fun slide, but somebody looked at all the different biomarkers for other neurologic diseases. So there's active work going on in looking at blood flow for Alzheimer's, and this is early. So we think with electrophysiology, it's up to 8 years before there are structural changes. So that's a good head start. So maybe all those failed Alzheimer's, I shouldn't say this because failed Alzheimer drugs is it's a hot topic these days. But if you use them maybe earlier on in the disease, if you attack the disease earlier, you're going to have better outcome. So let's focus on that. So let's use the eye as a tool to get insight into the body. And this is one area where I have high hopes that we'll be doing this. Tear fluid changes, corneal nerves change, pupil flash responses change. So these things are all seen, but the most work has been done in the blood flow, and now we're starting to see some more work in the electrophysiology. So this is exciting. Yes, more papers, always good to have scientific bang. So again, the message, disease begins long before we recognize it, get it at the risk factor level. When you see functional changes in the eye precede structural changes. Get the disease, it's not even, some people wouldn't consider it a disease. There's no structural change. Treat it like a disease. Be proactive about all of the measures that we have, nutritional, exercise, get it at that level, use the SLT, and you will avoid having that structural damage that we see all the time, unfortunately. And if you're not convinced, look at someone who has a B12 deficiency. Initially, their brain looks normal. With time and prolonged deficiency of B12, you get dementia and all kinds of horrible things. And the brain looks good. And then it's too late. We don't want to get to that stage. Okay. This was a patient who I had been following for glaucoma and high myopia, and his VEP was the one on the 9/18/2017. And he came back a year later, almost exactly a year later, and he had like all the indicators of glaucoma. And he's a young, healthy 47-year-old guy. I was like, what happened? You don't have high blood pressure. You don't, how could you? Because it was get some blood tests. He had not only a B12 deficiency, he had an anemia, he had a thalassemia. And when he started supplementing with B12, look what happened. We had nice normalization of the visual evoked potential, and the green gives you the hint. The patients love to see the green, and they see that, oh, that's a good sign. Yeah. So that's showing latencies are in the normal range. So neurodegenerative disease in the eye. Glaucoma is the most common neurodegenerative disease in the eye, for sure, and most common optic neuropathy. Different etiologies and risk factors we've talked about. The testing is important. If you are testing for damage, then that's all you will find. So test for dysfunction. Normal eye pressure doesn't mean you don't have glaucoma. High myopia means you have even myopia, even mild myopia, you have an increased risk. Your eye is a little bit longer. As you saw, the blood vessels are a little different. And currently the best treatment for addressing all types of glaucoma, both high eye pressure and normal eye pressure glaucoma, is the SLT laser. When that doesn't work, or if it's insufficient, then you can add drops. Typically, patients will benefit from repeat SLT. As I said, it doesn't burn, it heats, and the key is that it doesn't create any thermal damage, so it's repeatable. Severe glaucoma patients, they'll get it every 6 months. And it's covered by insurance, well documented. It's not even a debate. And it's painless when you get it. You don't even have to be dilated for it. So people like it. They like it better than drops. Initially, when I started doing it, I would give them the option. Do you want to be on a drop? After someone's been on drops, they sting, you get dry eye, you get redness, you get hairs growing out of weird places with some of the drops. There's a lot of side effects, not to mention the cardiovascular side effects if you're using beta blockers. So it's good reason to start with the SLT laser. I don't know why anyone wouldn't do that unless they simply don't have that technology available in their clinic. Let's talk a little bit about cardiovascular disease. This is kind of, most internists are aware that there are changes in the retina, and this is showing a picture of a test that used to be done where you could look at the pulsatile flow in the retinal artery by putting this Doppler transducer on the surface of the eye. We don't do that anymore. We can look at the eye, the flow, in a much less invasive way. But just to highlight some of the changes that you get in the back of the eye, and these are subtle sometimes. Sometimes they're very obvious. But I tend to count the number of changes that I see in a person, in a field. And follow that over time. And it is probably at least twice a day that I am telling this patient in front of me that although your blood pressure looks like it's good when you measure it, maybe at your doctor's office, most of the time it's high enough that it's causing these changes in the microvasculature. This is damage. Most of this damage arises from thickening of the arteries. They get a little thicker, less blood can flow through them. As they get thicker, they pinch the veins. That's what you're seeing right here, called an AV nicking change. When there's enough ischemia, you get little new blood vessel growing. And this is the test that we love. It's the OCT angiogram, non-invasive, but look at the beautiful capillary plexus that you see there. So that's the center of your retina, the macula, and within the center of the macula is the fovea. And that dark spot, you might ask, would be logical to ask, why is there no blood flow to that spot? Because that's your clearest vision. You don't want to be looking through a blood vessel. So all of these blood vessels are on top of the retina. They're on top. So light has to go around them. So most of the time you don't notice that, but in the sharpest central area, and there's enough collateral circulation there that it gets enough blood flow. Now, what happens in diabetes? It gets chewed up. You lose some of these, and you can see this beautifully without putting dye in someone. Sometimes people, I've had a friend with mild hypertension. He had little areas of dropout. You can see that without putting dye in someone. 2 minutes, we know that you already have damage. And so this is a beautiful test. It's real time, and it takes just a minute to do. Here's an individual who had a branch retinal vein. Branch retinal veins are super common in my practice. Lots of people have them. The number one risk factor is high blood pressure. Again, you can visualize it here. This is a lot of damage. There's no blood flow in that whole area that's dark over there. And this is what you might see in the clinic. You can sometimes get hemorrhages, all kinds of different changes. Then you do, this is the second type of angiographic test. This one requires dye, and it shows a little wider area in the retina. And you can see there's certain areas that light up more than other areas, and there's certain dark areas. Those are all indicative of problems. And so these are retinal vascular occlusions. So they come in two flavors: blockage of veins and blockage of arteries. Blockage of veins is very common. We have many good tools to deal with that. Blockage of arteries is a problem. Number one, it is indicative of more severe atherosclerotic disease, hypertension. Number two, people do not recover well from arterial blockade. So when someone has an arterial blockade, it should be treated as a stroke. And the protocol now in ERs is if someone has an artery occlusion in the eye, they should undergo treatment as a stroke patient. That is the new recommendation. So these are little mini strokes. And people who have had them, it's really bad news when they have it, but I tell them the silver lining is that we caught it before you had a stroke in your brain. And we'll typically have them get carotid Doppler tests, looking at the neck veins, looking at the heart valves. Are there any obvious sources of those little blockages? So artery occlusions, much worse than vein occlusions. Here's another vein occlusion. I just love the pictures. How are we for time? And the other thing that is happening is all of these images are being fed into deep learning. And what we're finding out is DeepMind looked at the UK database. The UK is wonderful in that the NHS keeps a really nice database. And so they have all these images, they have all this information. And so they looked through that database and they trained their models on those eye pictures. What they found is they could tell the blood pressure of that patient. They could tell, in fact, this is the stroke. So nobody wants to look at a table. Let me just tell you what it said. It said that with a high degree of certainty, 97% can tell what the blood pressure is in that individual. And you can tell, of course, diabetes, long time, we know how to do that. But to be able to tell the blood pressure, that was something new. To be able to tell the gender, that was new too. We don't even know really how this unsupervised learning algorithm did that. I think we have some ideas, but it was able to do it 97% of the time. Accuracy was amazing. So I think this is the future. I envision a day when you get a retinal photograph and you'll have a printout that'll say, hey, you have this, this, and this. You need to watch out for this. In fact, that day is today in my office, but I would like to see that everywhere. So that will happen. Good. So that is about all I have for my major points that I wanted to make. And I am open to more questions. Yeah. I think any.
What's the obviously, you know, a lot of people I was thinking for too, like I
So I think the greater risk to most people now is dry eyes because of the dry environment. I think there's an epidemic, and the dry eye drops are super expensive and they're inconvenient. It's better not to have dry eyes. So how do you avoid getting dry eyes? Well, evaporative tear loss is one of the major causes. So when you are out in the sun, make sure you have your eye drops. I like wearing a hat. You know, it's sort of like, you know, the good side of being outside is you get that light entrainment. The bad side of it is that your eyes are going to dry out. So I think protecting your eyes from drying out. Medications dry out your eyes. Autoimmune diseases dry out your eyes. Again, being preemptive makes a lot of sense. We have medications that suppress the immune response that allows our goblet cells and our normal mechanisms to restore the integrity of the surface to some extent. And that is one of the preventive measures. Wearing sunglasses, yeah, if it's super bright, yeah, wear sunglasses, but it's not one of those things that if you didn't wear sunglasses, you're bad. Okay, that's a good question. Yeah.
Thanks, Dr. Narain. We do have another question. Someone asked, how do we prevent macular degeneration?
So that would have been the next talk, which so macular degeneration is a polygenic, meaning many genes disease, and there's many forms of it. The largest study that was carried out, actually, I think is one of the largest in medicine, was the ARED study, the age-related eye disease study. And in that study, they were able to show that there were certain micronutrients that were really important to the prevention of macular degeneration. And when you restored them, a subset of people had a reduction of progression. Now, the problem was that it was only a subset. And when you see the vitamins in the drugstore, everybody buys them. Oh, I'm nearsighted. Let me get the eye vitamins. They're not going to help you. In fact, what the study showed, there were more complications from using those vitamins, including an increased risk of lung cancer from one of the components of the original AREDS formula. So they did a reformulation and they replaced beta carotene. So it was beta carotene that caused an increase in lung cancer. Like, oh, half the people who were using it didn't even need it because it only improved people with one category out of 4 categories of macular degeneration, 1 stage. That's all it helped. So my recommendation is not to most people who can eat. I tell them the leafy green vegetables, and that you're going to hear that over and over again. Dark green leafy vegetables. That's the talk that I give to the seniors, to people who are worried about macular degeneration. Spinach, lutein, kale, spinach, kale, collard greens, Swiss chard. There's a bunch of them, but the dark green leafy vegetables, they have the highest concentration, not just of lutein, but a whole bunch of polyphenol antioxidants that you don't actually get with that capsule. And you're getting a fraction of that, and you're putting yourself at increased risk. So the patients who I tell to use the supplement are the ones that are in that one category and who can't eat a good diet. They hate spinach. They don't like vegetables. They're not going to change. Okay, well, okay, do the best. It's not ideal. So it is your diet. The diet, the leafy green vegetables, the polyphenol-rich compounds is the answer. Yeah, it's a good question. Let me see if I have. Yeah. So Yeah, in our clinic, so here micronutrients for the eye. All of them are important. Obviously, we need all of these components for our bodies. There was some effort to try to prove that omega-3 fatty acid supplementation reduced dry eye and macular degeneration. Did not appear to succeed in doing that. It's not to say that it's bad, but it was not the answer. So again, I think you can't just rely on one factor. It's multiple factors. Yeah. So the beta carotene and cancer thing was real. That was a statistically significant bump. And on the current, and we didn't find that out until 5-10 years after the recommendation. So then they changed it. Now we have a new set of nutrients, and let's see what happens in 10 years. Post-market trials, right? So key antioxidants. Yeah, antioxidants are important. Another interesting factoid is the eye, inside of the eye fluid concentrates ascorbate. We didn't know why. It kind of makes sense because ascorbate is a free radical scavenger. And the most metabolically active part of the body is the retina. The most active blood supply in the body is the choroidal blood supply that supplies most of the nutrients. And so it makes sense. Hormones, this is another thing. So hormone replacement therapy, they found that women who were postmenopausal were more at risk for glaucoma. Hormone replacement therapy appeared to benefit those. So there's a couple of studies that have come out showing that. They unfortunately used endpoints of IOP reduction. As I just explained to you, IOP cares about IOP. The normal range is 8 to 21. If you're 20, does that mean IOP is less important than your actual vision? So if they had measured nerve function, they probably would have had an even greater success. But even with reduction of eye pressure, even using that faulty metric, they were able to show some argument in favor. Too much steroid can cause problems in the eye. So again, hormones are important. Steroids can cause all kinds of issues in the eye. In addition to cataract, you can get some retinal fluid. One of the most common things I see is a condition called central serous chorioretinopathy, or CSR. It occurs, we think, in people in Silicon Valley. It happens all the time because people are type A, high stress, and probably have a natural baseline high level of glucocorticoid production. So all of those factors correlate with this condition. I see it a lot in Silicon Valley. We found, and others have shown also, that testosterone blockers, which are popular for men with prostate cancer, can affect the retina as well as the central nervous system. And that's because a small amount of androgen is necessary for normal, healthy, functioning eyes, both in men and in women. So you don't want to absolutely block it unless it's a life or death. Yeah, so this is our study on finasteride. Finasteride is the hormone blocker. You'll see a lot of patients on it. It's been banned in some countries. There's lots of there's a support site for people who have been on finasteride. What's interesting is a subset of these patients who are on this appear to have prolonged effects even when they discontinue the drug. It's a little bit scary. And it was released by Merck. So beware. So really, we talked about like what you can do. So some of the more proactive things to consider if you had glaucoma or some of these conditions, hormone replacement helps some of the baseline function, micronutrients, SLT for glaucoma. RF energy is now used for dry eye and meibomian gland dysfunction. And of course, something we can all do is sleep and exercise, go outside. Lots of things that we can do proactively without needing anything special. And sorry, I'm just running. We're done with the main body of the talk. Lots of work being done on how we can regenerate the optic nerve. that's nice, but how about if we tried not to damage it in the first place? Or when we recognize the early stages, do something at that point. Because the treatments, the gene therapy treatment, the first gene therapy treatment that came out was for an eye disease. It's $850,000. So not everybody will have access to that. And it's for one type of retinitis pigmentosa. So these things are coming, but it's not going to be widespread, and it's going to be a very limited number of people who initially get it. So again, focus on the preventive aspects, what's proactive, nutrition, exercise, diet, and your annual exam, your annual eye exam. Ask your doctor, are there any signs of high blood pressure in there? How does my nerve look? You know, can you ask them if they do objective visual, objective optic nerve testing, objective functional testing. Most of them don't. Yeah, so I'm going to leave it at that, and thank you for your time. I've left my my email, and my practice is southbayretina.com. You can find me on the web. If you have questions, you can certainly email me. I'm happy to talk in more depth if somebody has specific issues. And yeah, I won't go through cases because we don't have time. Thank you.
Yeah, thanks so much, Dr. Narain. Thanks so much for your time. Great presentation. Thank you so much.
Oh, my pleasure. Yeah.
All right. All right. Well, good night, everyone. I don't have any more questions here. Thank you so much for everyone who attended. Have a nice evening. Bye-bye.